I will explain a bit about our system. This, you see, is the Da Vinci robot-assisted surgical system. It has 4 arms that can move individually and replace the surgeon's hands in the patient. This is the vision card where the surgeon actually sits and can control little small instruments that are in the patient's body. The surgeon can sit really relaxed at the console and move his wrist, see stereoscopic and high definition, and control small instruments in the patient body. Here you can see an example of somebody suturing a wound. And actually the degree of freedom of the surgeon is larger than the human hand. You can specify a certain surgery for a certain patient by preparing it individually. The instruments enter the body through these ports and so-called trocars. And this is the camera, the vision of the system and the surgeon at the same time. Welcome, ladies and gentlemen, to the first intuitive masterclass ever at Europe 20XX. Today's session is titled The Future of Surgery, Advancing Care Through Innovation. My name is Joachim Hayes, and I'm in charge of government and public affairs with Intuitive Surgical for Europe, and I am your moderator and host today. Intuitive, you might have guessed, is the developer and producer of the Da Vinci robotic-assisted surgical system, and we have the ambition to improve minimally invasive surgery for patients, their families, surgical teams, hospitals, payers, and the society as a whole, and all at the same time. That is truly a lot to achieve, and we will spend the next hour or so on diving into a couple of aspects that might give you a new feeling for what surgery can become and how technical innovation is improving patient care. But let me start by introducing the brilliant speakers of today. No echo anymore. Before joining Intuitive in 2013, he had various executive positions in marketing, medical, and sales with leading companies. He holds an MD from the University of Mainz and an MBA from Cardiff University in Wales. Do you speak Welsh, by the way? Whereas Tillman will speak on the development of surgery as such, will present some of our technology and the benefits of a digital ecosystem around it. Our second speaker will give you a glimpse into the reality, which is certainly even more important. Professor Amit Mergeli is head of the Department of Urology at Vivantes, Berlin's largest chain of hospitals. As such, Amit Mergeli is in charge of both surgery in urology, which he does every day. I've been in his OR and was deeply impressed. And he's also managing not only the urology department at his home Klinikum am Urban, but across all Vivantes hospitals in Berlin. While technology can do a lot, it will only benefit the patients if it is actually applied and used in patient care. Amit Mergeli knows, and he will report from his practice today. Each of our speakers will speak for about 20 minutes, followed by a short common discussion. I will start this third part with a couple of thoughts from my side, but please be prepared to ask whatever you have always wanted to know about robotic-assisted surgery. Thank you very much. Tillman, the floor is yours.
Joachim, thank you very much for your kind introduction. Ladies and gentlemen, it's a pleasure to welcome you as well from my side. I'm honored to be here and really open to anything that you think is relevant. Maybe one lead thought before we start. Either yourself or someone that you know may have a cancer diagnosis. And if you have or know someone, this talk will be more relevant as surgery continues to be one of the major factors in cancer treatment. It's not only a drug, it's still someone, like my colleague, who will help you in such a situation. Actually, as a surgeon, sometimes I am very thoughtful about what I do. Can I be better? I ask myself the question, can my treatment, my surgical treatment, become less invasive, less trauma? It also leads to a question, is there a need for improving surgery? If I talk about surgery, I'd like to introduce you three perspectives. One being an open general surgery, big cut, big surgeon, right? And in the past 30 years, the development of minimally invasive keyhole surgery, which you see in the middle, handheld instruments. And you see to the right what we call robot-assisted surgery. And today's talk is to describe where we stand in this development, but also where are we thinking we're going to take this. It started actually brutal simple. It started in a time where this gentleman was still alive. It was someone who clearly changed our world of computers. He had that craziness that it took to really change our computer world. At the same time, and this is my point here, Intuitive was founded. It was in the 1995s. And at that time, robots were developed in a lab, screwing technicians, working on building something. But why in the world would we do this? What mindset is relevant, or what G. Stopp was thinking about? It's a mindset that all unifies people that work for Intuitive. It's putting someone into the middle that is the most relevant, the patient. Always first. It's the same mindset that took us through the following 28 years. And you see a whole history of different developments. It started to be relevant in hospitals in the near 2000. Actually, the first prostatectomy in the world using a robot was done in Frankfurt, Germany. And ever since, new generations, like for laptops, appear and come to the market. And everyone is a little bit better and has an evolution behind it. And the very last system over here is a system that no longer requires 4, but only 1 access port. We will talk about that in a minute. And another technology in a different space even requires 0 port to access, where we can treat. There's a lot of work behind. Lots of people, many ideas, many concepts. You need to really carefully understand what it takes to be in the OR. What is a surgeon really doing? How can we help? We found one of those principles that is key relevant for surgeons. See better, do better. You need to look at where it really matters, where you make a difference, where you as a surgeon take the most relevant decisions for a patient. It's inside. I'd like to show you something from inside. Don't worry, you're going to be not seeing one single drop of blood. It's a careful dissection of tissue with no blood. And you not only see blood vessels, and if you see them, you don't need to cut them. And if you see a nerve, you don't need to cut it, but you need to see it first. If you do, and if you can spare that nerve, it's going to be very relevant for a patient. It is directly linked to quality of life. My colleague will speak more about that. And over this same time frame of almost 30 years, Intuitive was able to place about 9,000 systems on a global scale. In the last year, only 2.5 million procedures were performed. In a total, we oversee 14 million procedures. And this has, of course, in the scientific world, where scientists validate our technology, and we do see almost 40,000 scientific publications talking to various aspects of value that is relevant for patients. Europe, let's have a look on Europe. We do see about 1,500 plus systems that were installed. We oversee about 10,000 surgeons that are 100% trained to use Da Vinci technology. And German or European researchers produce about 1/3 of the clinical evidence available today. In total, we served about 2 million Europeans using this technology. On the other side, you see a couple of centers where we invest as a company, where we believe here is where we need to produce and manufacture parts of that system, but also these are centers where we train surgeons. So for us, Europe is a key area in the world that we are focusing on and supporting by having all these points across a landscape here. If you think about innovation in surgery, I think you have a justification only in the case you are able to solve a couple of tough problems. What are the tough problems today? So it's all about the patient. I said that. The patient is benefiting from better outcomes, from better clinical results, from a faster rehabilitation. But also the way how care is delivered is a key question for our patients. So how is it my recovery phase? How well am I prepared to go back to work? This is very relevant to a patient. And at the same time, we're not ignoring the fact that costs in healthcare play a key role. It also addresses something that is a clinical and a surgical truth as well. It's all about variation. Surgeon B does this, surgeon A does that for the same procedure. Which one is better? You will find the secret if you standardize. That will have a cost impact as well. There's some more gap here, right? It's about people who deliver care. They are key people as well, as they very well impact cost efficiencies again in the OR. An OR, no doubt, in a hospital, it might be the most expensive place in a hospital. Let's have a closer look to this. To complete, let's say, some European picture, we note that these people delivering care are challenged. It's not only after the pandemic, but also the number of positions unfilled becomes really a problem, which causes patients to wait. Can a cancer patient wait? No. Another thing that is relevant, that staff shortages again lead to a couple of consequences that are not in favor for patients. So let's address that. Is it possible to do this with a computer system, a computer-aided OR system? Yes, you saw one little trick in it This system has 4 arms. It's no longer a surgeon with 2. And 4 arms that are controlled by 1 surgeon may open up opportunities to lower the burden of your staff in the OR. But more than that, it's not only in the surgery, it's before as well. Imagine if your surgeon has more time for you. Imagine if that surgeon is not in a rush. He's able to address patients' concerns and anger and concern about a very severe disease. And if he would be able to have information relevant for that case at his or her hand, not running around in the hospital trying to collect data, have it directly in your hand. It continues during the case. I said to you, seeing better is doing better. So a computer in the OR will enable you to see better, to see vessels, and to compare it to a white light picture. It's a specific technology that allows to see perfusion and to see blood vessels. Again, if you see them, you can spare them, and it will return into better clinical outcomes. I show you something that is a little miracle for surgeons. You know, stapling is a process to create an anastomosis, meaning a connection between 2 different tissues. And this device works like a stapling device that you use on a paper as well. And it does exactly the same. And it's a miracle because you don't really see what happens there. What if the computer helps you? And I quickly illustrate, you see all these little things here, those staples that go into the skin, bringing 2 tissues together. And you see the system is measuring data, and this data will help the computer to make a better decision that all of a sudden you see, and you measure what is taking place down there and what helps me to create a better, a more safe connection of tissue. It's more than that. It's again during the case, I may face a situation where I need help. From where does that help come from? We just discussed there's not enough surgeons already today, so I can call in someone by remote. You can call it a Zoom. We all know this technology by now. It happens in surgery as well. This is, again, a hardware aspect. You need a place where you connect and you collect all these data, which is just a piece of technology, hardware attached to the system, which allows you to give you data again when you need it. Translate this into an app. You can use this with a discussion for your colleagues. You can use this in a discussion with hospital leaders into what is the reality? What am I doing? How many of what? And what it translates into, and what does it mean? And if I were a hospital administrator, I want to know as well. I'm very much concerned around costs. So let's see it. What are the costs? And what is the benefit of it? Here is something what you also need to memorize if you introduce innovation into patient care. It is how you train a surgeon to become very safe and efficacious on that system. And it's, as you can imagine, no longer a patient-required, nor any model. It is really on simulation. A surgeon can learn about innovation using simulation. And I'm taking you one step further. With robotic surgery, first time ever, it is possible to observe what the hands of a surgeon are really doing. And we can collect those movements. All these movements are nothing else but data. And we're using this data in order to differentiate between an expert and a novice. And we will teach the novice to become expert. So we know what good looks like, and we know how to bring patients from a novice to an expert level. And we translate this into the simulation again. It's simple. It's holding a needle, but this is significantly changing the efficacy and the speed of a surgeon. I need to take you a little bit further into the digital space, as no wonder future of surgery will be digital. Think of it this way: 14 million data sets serve us as a very sound basis to improve heart for patient care. Just a little thought. Imagine we could predict patient outcome. Would that be valuable? Think again, how about if the consolidated experience could be in one place? That one surgeon is not only relying on his or her personal information and experience, but bring in thousands, thousands of cases of experience worth in data. That is a moment where it becomes very, very challenging, but interesting as well. The way how we think is like this. Data generate insights, and insights again generate actions, and those actions again back lead to data. And if you continue to use this circle of innovation, you will see better outcomes in the OR. You will increase the efficacy of your teams and use resources more wisely. We believe that digital will have a significant impact on outcomes, as well on learnings, but also on the cost aspects. It will be relevant not for surgeons only. It will be relevant to all patient givers in a hospital. They all rely on information and having these access to that innovation and to that data. And guess what? We don't do this alone. It is something that we need to develop together with surgeons in order to be on track. They know what they need, and we know what we can technically deliver. So we aspire a very tight collaboration in that surgical community. You saw that one already. Again, it's a next step, bringing the access trauma down, making maybe surgery possible through one incision, but also through natural orifice surgery. So no port required, no trauma to access the anatomy. And this is another aspect where we believe how innovation takes. So it took us a couple of years to hit 1 million of patients. And we believe that we will touch significantly more patients in the next 10 years to follow under a precondition. We as a community need to focus on advancing and speeding up patient access to innovative surgery. And we need a regulatory framework, and we need a political framework and a cost framework, and many, many more. So we cannot do this in a silo. We need to collaborate. This is what we can see. We can see we will touch more patients. And we will be able to do this together with you, as innovation is not a place where you just go. It's a place that we create together. Thank you very much.
So now we will have a look on more practical aspects. I'm a surgeon, I'm a urologist. My main focus is prostate cancer, so I do perform procedures for prostate cancer, removal of the prostate. And I'm happy, dear audience, to guide you through this process of the revolution or the evolution of robotic surgery. And imagine a world where the surgery is not only precise but also highly efficient, and where the boundaries of what's possible are constantly pushed on a daily basis. And this is not in the distant future, this is happening right now. We are not there yet, and this is thanks to robotic surgery. We are not there yet where the robot is doing the surgery on its own, but if you look at the technological developments over the past few years, such as AI, such as engineering, I think we can't imagine now what will be present in 3, 5, 10 years. So this is, from my perspective, a realistic scenario. And the success of the robot, of the surgical robot, is the success of the radical prostatectomy, of the removal of prostate cancer. Prostate cancer is, as you might know, the most common cancer in men. It's very similar to breast cancer, the most common cancer in women. If it's detected early, it can be cured by removal of the cancer. If it's detected late, then there's no cure. So key is to detect the cancer as early as possible. And the first procedures of removal of the prostate were done in 1902. So this is more than 120 years ago. And then it became more popular in the 30s, 1930s. But the problem was there was excessive blood loss. 10% of the patient died during the procedure. There was erectile dysfunction in every patient. Removal of the prostate meant no sexual intercourse anymore. And the majority of patients were incontinent, so they couldn't hold the urine, and this was obviously associated with a severe impact of quality of life. And this is because of the anatomy, and this is very simple. I'm not a big drawer, as you can see. So this is the bladder, this is the prostate, the urethra, the tube goes through the prostate and ends in the penis, and there are two structures which are very important. It's the sphincter. This is the muscle holding the urine. So if you injure the sphincter, the continence is gone. And these are the nerves which are beside the prostate, which are responsible for the erectile function. If you remove them, the erectile function is gone. And it was thought that the nerves which are responsible for the erectile function travel through the prostate. So whenever you remove the prostate, the sexual function is gone. But we didn't know much about the anatomy. So it was key to understand the anatomy and adjust the technical surgical approach. And this was done by Professor Walsh in Baltimore in the 80s. So 80 years after the first procedures were done, there was one guy who realized, I have to look more into the anatomy, understand the anatomy to improve the outcome of the surgery. And I had the big privilege to work with him for 2 years when I was in the States and worked there as a surgeon and learned much from him. And this understanding of the anatomy and also the spread of the news, he was very open in sharing his insights to the whole urological community to improve surgery, not only in the United States, but elsewhere. And this was in the 80s. And you can see, if you look at the number of prostatectomies increased significantly with the understanding of the anatomy, making the procedure more safe. But how was this development possible? It was possible because of outcome research. You have to ask the patient after the procedure how they are doing. And the outcome measures which were observed were continence, erectile function, but also complications and general quality of life. And if you measure these outcomes, you can adjust your technique, improve your technique, and improve your outcomes. And we started with the classic open prostatectomy in the 80s. The new technique, as I described earlier. Then was the minimally invasive laparoscopic prostatectomy, which was also mentioned earlier. This had the advantage of not a big incision, just very small incision, but it was not so delicate in preparation. So if you want to preserve the nerves, and if you want to preserve the sphincter, so continence and erectile function, you have to have really delicate preparation. And this is not possible with a laparoscopic minimally invasive approach. You can remove a gallbladder, no problem. You can fix a hernia. You can take out an appendix, because 1, 2, 3, 4, 5 millimeter doesn't matter in these procedures. With a prostatectomy, preserving the function, millimeters matter. So that's why it is important to have a different technique. And this was the robotic approach, where you had the preciseness of the open procedure and the minimally invasiveness in one procedure. So that was a breakthrough. In 2000 it started. And whenever in medicine we want to establish a new technique, we investigate it with studies. And the classical way is a randomized trial, where you have 2 patients and you choose one to use this technique and the other one to use another technique, and then look at the outcomes. And this is one of the few studies out there looking at incontinence, erectile function, and also complications, cancer removal, and for the open and for the robotic approach. And they were pretty similar when it comes to incontinence, erectile function, and complete cancer removal. But the robot was better when it comes to complications. And one of the very important things looking at these data is that the robotic technique was new and the open technique was established. So what they did here is they looked at a very experienced open surgeon and a very unexperienced robotic surgeon and compared these two. And as we have learned over the past years, experience of the surgeon is one of the most important factors when it comes to the outcome. This advances in robotic surgery led in the United States in 2015, so this is 10 years ago, to the fact that 90% of the prostate removals were done with a robot. So the United States were always ahead of Europe and Germany when it comes to innovations and new surgical techniques. For the other organs, maybe only like hysterectomy, also pretty big proportion done with a robot, but other specialities very rarely. This came later, colon surgery, other indications came later. So does the robot keep what it promises? We have heard the guy from Intuitive, Tillman, presenting his product. So for me as a surgeon, can I go in the same direction? And this is something I want to have a spot on right now. Benefits for the patient, if done by the right person, very important, for the surgeon themselves, and also for the healthcare system. So, and we have seen this earlier. If you look esophagus, for example, if you have cancer of the esophagus, it's a horrible thing to do the surgery on, because you have to cut the patient open from the chest until the lower abdomen. So it's completely open, and there's wound infection, there's pain, there are a lot of complications. And if you do the same procedure with a robot, it looks like this. Much better for the patient, also much better for the patient to accept to undergo the surgery. What you always have to keep in mind, what is happening inside is exactly the same. So this is still, despite minimally invasive approach, a big surgery with the potential for complications and so on, but less wound infection, less blood loss, less pain, and more appealing for the patient. Preciseness. I just mentioned that we have to be like really precise when we want to preserve the nerves which are responsible for the erectile function, and also the sphincter for the continence. And this is a video present in the internet where the Da Vinci robot was used to peel a grape. And as you can see here, the preciseness is really unseen. This is something you might be able to do open. You won't be able to do this laparoscopically. It will be like grape mousse at least, but not peeling a grape. And if you do it openly, you still have the tremor. You're still a little bit, you can't hold your hand 100% still. And this is not happening with the robot, because this is all filtered. It makes you better. It makes you more flexible in what you can do. The robot allows you to do things you can't do with your hands, and to be even more precise. And you have a magnification. You see the grape 12-fold magnified. So this is also a big advantage when it comes to small structures you want to prepare. So what about the patient? How does the patient benefit? The patient benefits from less incontinence, less erectile dysfunction, shorter hospitals. This is long-term, but also short-term, shorter hospital stay, less blood loss and fatigue after the procedure, and also less pain after the surgery. So this makes like the fear of going into surgery much less, because you only have a short hospital stay. You don't lose much blood, and you have little pain after the procedure. So these are like very convincing factors for a patient when he, in this case, or she undergoes surgery. What about the surgeon? So this is a picture of me on the right side at the console 2 days ago. So this is pretty comfortable. I'm sitting there, I can adjust the robot to my height, and everything is I can put like a Diet Coke here and have a drink during the surgery because I'm not sterile. I'm not touching anything. And this is my colleague Stefan, who's doing last week, who's doing an open procedure. So he is operating in the small pelvis. So he's standing like this during the surgery for about 2 to 3 hours. And if you do this the whole day, 8 hours a day, and if you do this your whole life, you won't do it your whole life, because there will be there will be a stop at some point, because this is not healthy. And this is really very comfortable for the surgeon. And when you think about shortage of surgeons, limited capacities for surgeries, this is an important factor. What else for the surgeon? We have heard this already. When you start, at least with the company Intuitive, the new companies which are coming, they still have to establish the network. But when you start with the surgery, you have a structured program. So you don't go into the patient, do your first surgery. You start with the simulator training. You learn how to use the system, not at the patient, but as a simulator. You have a wet lab training where you operate on pigs and catheters. With a new simulator, this can be reduced significantly, because the simulations are so near at the real experience in the operating room that this might not be possible, might not be necessary in the future. Then you visit other centers with experienced surgeons. You look, you watch, you observe, and you learn from each other. And then you do your own first procedure. And this is where a surgeon, an experienced surgeon, a so-called proctor, visits you and helps you with the first procedure to make sure everything goes well. I'm a proctor for Intuitive, so I travel to many other hospitals and help the surgeons there, and I'm going somewhere tomorrow to do some proctoring. So this gives you a lot of confidence as a new surgeon in this field. And then you can track your own progress with the Intuitive app. So I have my app on my iPhone, and I can see how many procedures I've performed, how long, which sort of procedures were these, and how long did it take. And this is an example, we've seen it earlier, of the simulator. So here, the trainee, you can see him there where he's moving the instruments with his hands, is learning how to stitch. Should come in here, the needle should come out here. And this is something you can train in the simulator. You don't need the patient for that. So when you start operating on the patient, you're safe in using the machine. And it's like driving school. I mean, it would make more sense if they learned how to use the car in a simulator and then go in the real car and start it, because you're already comfortable when to push the clutch and so on. So that makes absolutely sense. And this is tracking of your own progress. So this is a screenshot of my app. So these are the last 1,700 cases. This is the average duration of the surgery in Europe, with the first 10, 20, 50, more than 100 cases, so you always get faster. And this is the top 10 average, top 10 surgeons in Europe. And this is my results of the procedure. So I'm within the first 10% of when it comes to speed of the surgery. So you can track your own results and see how you're doing compared to the other European countries. So what about the healthcare system? We have a shorter hospital stay, we have less blood loss and complications, and we have better functional outcome, which translate into less cost. Less direct cost, shorter hospital stay, but also consecutive cost through less need for treatment of incontinence and erectile dysfunction. And this is a strange thing. So these are the results for continence in certified German prostate cancer centers. So every bar represents a center. And this is a special score to evaluate continence. And this reddish thing here, these are patients who are really continent. And if you look at how many centers reached this completely continence level, it's pretty, not many. It's not many. This is like okay continence, and this is like bad continence. So despite the fact that these are the results of so-called centers who are certified, who are visited, which are visited by people observing them, the results are not ideal. And this is because volume matters. So you really have to do this surgery a lot to have good results. And you have to specialize, and you have to concentrate this surgery in specialized centers. Because a fool with a tool is still a fool. So if you give me a Formula One car with the newest edition, I won't get it from my yard, and I won't win a race. So having the robot doesn't mean you're doing good surgery. You need to have the experience, you need to have the volume, and you have to have a structure in the surgery. So every surgery is structured and goes the same way. So what are the future direction? Specialized centers, I already mentioned it. Development of single port system, we have seen this. This is by Intuitive, but there are also other companies working on this. Remote surgery. So if a surgeon has a problem somewhere far away, I can log into the console, into the robot, and help the surgeon because I'm experienced and I might be able to have a solution to the surgical situation he or she is at. Development of endoluminal surgery. This has been mentioned before. So right now when we're going through the prostate, we're still going through the abdomen. Right now when we're going through to the bowel, we are still going through the abdomen. But what about going to the bowel through the bowel? Fixing it, suturing it, taking the instruments out. There's not even a hole in the body. So this is something which is happening already. And also implementation of AI. We are using in medicine a lot of AI already for diagnosis, for diagnostic. So if you get an MRI of the prostate because there's a suspicion of prostate cancer, we use AI right now to evaluate the pictures, and they are better, the AI is better than the radiologist actually to find the cancer. And this has been more and more implemented into robotic surgery also. And this is a little bit grayish because this is a little bit more in the future. This is happening right now. Development of independently acting robotic system or miniaturized systems where you actually let the robots go into the bloodstream or into organs, fix it, and come out. But this is much more in the future. So what are the obstacles? Europe and especially Germany are no longer at the forefront of medical research. Because the environment, we had this discussion earlier, the environment is not very friendly for these developments. And also the approval process for medical devices in Europe are very complex. So for example, the single port system of Intuitive has had its approval in the United States in 2017, I believe, or 18. And in Europe, just now, so 7 years later. In 7 years, it has been used in the States. They have gained experience with the system, and we needed 7 years to get the approval for this system already working in the United States. And also data protection is always a big thing. So for example, we have the hub, so we can, in our institution, we could record every single procedure, go back at the procedure, look at the pictures, how to improve your technique. We have also systems of AI looking at the operating videos and maybe finding situation where improvement could be implemented, but we can't use it because we have data protection restrictions. Although it's been used all around the world, the hub, even in Germany, in different institutions, but at our institutions, we have the last 2 years we're working on solve the problem with data protection. So this is a big. These are the big obstacles we're having in Germany when it comes to innovation in robotic surgery. So thank you very much for your attention, and I'm looking forward to the discussion.
Yeah. Thank you very much, Professor Mageli. Tilman, please have a seat. And I will sit at the edge. These were impressive presentations from the technology side, from the company side, from the practice. And we're very far from the OR usually. We only go there unconsciously, if we go at all. And one question that really sprung to my mind quite spontaneously was, yes, we're not at the forefront of medical progress and science in Europe anymore. This is something we heard in the morning as well in the pharmaceutical session. If you were the politician, what would you do right away? What would be your 3 first steps as how to improve medical research and progress in Europe and Germany?
Well, I think, so the first thing is we have the physicians who are eager to do innovation. So that's not the problem. And we have the companies. And we have like, I think a German mindset of quality, which is also, I think, especially when it comes to trust into technology, I think it's an advantage for Germany. It's just the administration, the regulation, it's just too complicated. I understand that the process of regulation is necessary, but it has to be thinner. And hurdle, they have to be lower. I think that's the only thing. Otherwise, the setting is perfect in Germany.
Yeah. So it's more about an equilibrium between incentives and hurdles to guarantee safety.
Correct.
From our perspective, I believe, as I said in my presentation at the end, we do have and we will have more technologies that will have a significant impact on patient and their quality of life. The question that we ask as an industry partner in this is to advance and to speed up patient access. And there are barriers, not only costs, but if you think as a manufacturer, there's a big hurdle to get a CE mark, meaning a commercial permission to sell. This is a big hurdle. And there's others, such as our system of evidence-based medicine. We're not against evidence-based medicine. We have a lot to say. What we would need, maybe I speak up, no, it works. What we need is a support and an appreciation of reality. I'm referring to real-world data that are collected all everywhere. And these data, these patient experience must count when it comes to health technology assessments. Just to mention 2, and there's more. Think of us as an industry very relevant to jobs as well here in Germany, where we also need to build conditions in which an industry is interested to invest here and not abroad or in other countries. So a lot of actions, and there's more.
Thank you, but let's start with this evidence-based medicine and go beyond. I would like to build on your insights from data generation and usage. So if a patient is treated today and data is extracted, the patient today will not necessarily benefit from this data generation, but the patient 5 years from now. Once there is the big data generated, the data that can be used for giving some advice. But this is the question to Mr. Mageli. Would you really appreciate the robot, the computer telling you, think about doing the surgery like this, or would that be a bit too much?
Well, I guess it depends, especially when you start with the procedure, every help is good. And if you're very experienced, you can almost manage every situation. But I think in the beginning, it would be really a big advantage if you have some technological support or someone giving you advice how to proceed. Every help counts, I think.
Yeah.
If I may add to this, if you think a pilot today is using AI and computers every day, and still there are 3 pilots in every airplane. Why is that? What do you think? Why not the same principle applies to surgery, as he said, when it becomes difficult, when I cannot see well, why not accept a technology helping me see better, right? So it is the equivalent that we see frequently where technology can help.
Thank you. How do you think society, was there a question?
Yes, I have a question. I'm not an expert here.
Well, then jump in.
Hello. I would like to know what the vision is, because I don't know what the current status is. Is it like every doctor does their own operation every time again and is learning, obviously, and maybe someone else is jumping in from remote? But is the vision like that the robot knows, like, okay, this is this and that operation, so I help you how to start, blah, 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 and you're just supervising the technology, or where are we, and where are we going?
That's a tough one. Go ahead.
So we don't know right now, but what we know is that sometimes during surgery you need help, and if the help could be from a technological advance, I think you should use it. So orientation in a lot of patients is a problem when you start with the surgery. You don't know exactly when you're cutting where the next relevant structure is. But you have MRIs and CT scans and everything of the patient, and you could use this information into the operating room to navigate, like Google Maps, so you know, oh, it's only a little more step ahead, and then I'm in the prostate, a little more wider back, I'm in the bladder. So I think this will be the near future. Have navigation during the surgery to help you to say, oh, there's a vessel, don't cut, alert, don't cut, there's a vessel in the MRI, stop, or be careful. So this would be helpful. Autonomously, like driving on its own, and you just sit there and watch and say, oh, stop, now I have to interfere. That I don't know when this will happen. This would need more years, but right now this would be really helpful navigation during the procedure.
Quickly add just to what you explained to answer your question. It's not the case that some robot is operating on its own. That's not the case today. So today, every minute, every second, the surgeon is controlling and is accepting help if required. Okay? What the future will bring, I don't know. We do have a vision, but think also of it that from an ethical standpoint, you know, if you think ahead, a patient always requires a human to be the treating person, and I think it is an important key to have a surgeon, a real one, at least involved into it. I don't see it that it's going to be fully automated yet.
There was a question.
Yeah, connected question, and thanks a lot. I mean, this is just amazing, yeah, and saving so many lives and anything, yeah, so fantastic. 2 questions. So, I mean, you rightly said a fool with a tool remains a fool. So, I mean, do you issue something, I mean, like the driver's license, the Da Vinci license for, you know, surgery, for you know, people doing surgery? And then the connected question to that is, I mean, assistance via, you know, it's like from far away is the one thing, but you could also dream and say, hey, I mean, there are specialists all over the world who could do the surgery remote, because in the end, I mean, if you sit next to the patient, or if you have a surgery team at the patient and somebody sits at the same machine wherever in India, or, you know, and does the same stuff, and he's a super specialist, in the end doesn't matter. So how far are you with that?
So maybe for the driving license, in Germany, if you're a physician, you have the driving license for all vehicles. You can do whatever you want to do. So if you decide to buy a Da Vinci system, and if you decide to do one procedure per year, And if you decide to do this at the age of 80, you can do it if the patient gives its consent. So there's no restriction. Everything is restricted in Germany. Data protection, a CE certificate, and so on. But if you're a surgeon and you decide to do a procedure, you can do it, no problem. No matter how often you do it, how rarely you do it. So that's a problem, but this is addressed by the new laws which are coming probably. And with the hub, with remote surgery, yes, there are always situations where there might be an emergency where you have to be present to open the patient and fix the emergency. This happens rarely. This has never happened to me in many thousand procedures, not once, because there's a good patient selection for the surgery. But it could happen, and then you have to make sure that there's a team present which can handle this emergency situation. But if this is present, I think it's possible, yeah.
Maybe just my perspective to your very good question. We invest a lot into training. We believe this is key to make successful, to achieve good results. Don't forget, we have patients in mind. It's not all about technology, it's patients. So what do we need to do to achieve this? They need to have a technology training, you know, how to use technology on one side, but then there's a big surgical community which is on how to use the technology right. What are the tips and tricks? How do you use it? What can I learn from you? So this big community is helping a lot to achieve these. And remote surgery, I could talk for hours. It's a fascinating aspect, but it's maybe more, it's technically possible, yes, and it will help us in some way. We're right now finding and better understanding how this really works.
There was another question in the back, or here at first, yeah?
Yes, just again a quick question. Looking at the robot, it's not really a robot, it's actually a gearbox, a very expensive one combined with a magnifying glass, but it's not a robot in the sense that we use robots, for instance, on the production side. So when you look what happens at the moment in automotive production, you combine these robot arms with a lot of artificial intelligence, meaning image-guided, moving, putting stuff together, soldering, gluing, whatever. So that would be, we can really see that this is really a next step in automation level. Is this something that you also think that you could do with the Da Vinci gearbox, which is not yet a robot? So you could combine artificial intelligence with, with the mechanic ability that you have at the moment?
Yes, the answer is yes. And you're right, I agree with you. It's not a robot, as it is not an automated process, and we are proud of this, as we are not yet at that level. And as patients have different expectations, the question really is a patient willing to undergo a fully automated process like a car? We're probably comparing two different things here.
Why did we do it in cars? Because hands off and you get cars with a much higher quality. Don't you think that would be the same on the surgical field?
That is my point. That's exactly the area of question. Where can a system like Da Vinci can be better than a surgeon's hand? And what are the places where we better rely on a personal experience of a surgeon treating a human? That's exactly the debate that we're having. And we answer these questions for a couple of things. Tremor filtration. You know, a human, we know, will have always a tremor. You cannot eliminate, a robot can. So there is a decision made. What is better by a computer or robot? Or what is better in a surgeon's hand and in a surgeon's decision strategy?
Although I would like to add from the policy and legal side, of course, that there are requirements and there needs to be that surgeon in charge at the moment. And we are a company, so we are producing the systems that are complying with all legal regulations. And therefore, yes, we think about this. We think about automation and what could be possible in 10 years, but we produce the product that is legal and applicable right now, and that must be controlled by the surgeon.
That's maybe just one more thing. It looks all the same. If you look into the human body, it looks all the same. There's fat around the bladder, there's fat around the prostate, fat around the rectum. You can't discriminate. and you don't have clear structures. They have different hardness of the tissue, which you can see when you touch it. So these are all like many subjective things which the surgeon with a lot of experience can realize. It's not like a car where you have your wheel, you have defined structures. Everything is very flowing, and then the tissue is different. Some tissue is stable when you suture it. Some is not stable. You can see it, you can feel it, but it's very difficult to measure. So I think that's a little bit more complicated in the human body compared to other structures.
It's not. That's exactly where you have artificial intelligence. You know, you as a surgeon, you have been doing for how many cases? Thousands.
Thousands.
Intelligence could take all experience of all surgeons and combine it. And this is exactly what we also do in all the fields.
Thank you for the input. Let's follow up on this during the break. I would like to ask the last question and then come to a closure.
And it's related in that you have to have the data. I want to ask, what are the real problems with data protection? Because, I mean, everyone says data protection is blocking us, but if you have the full consent of the patient, where's the problem? Is it the regularity office, or?
Yeah, we're not allowed to record the procedures.
I mean, the patient
data
can allow it and
protection.
you are still not allowed. Yeah?
Say it again?
The patient can allow it, but you are still not allowed.
No, as an institution, we have a data protection policy, and we have to have the approval, and the approval is not given. So we can't do it.
Oh, that's a real pity. Yeah.
So let me combine, because we need to go back down again. I see the register, the order there. One word, what you wish for. What's the perfect, I'm the fairy tale, how should surgery be 2030?
Well, I'm happy right now, to be honest, with the situation, but I wish for a lighter weight for innovation.
Thank you.
I think the future must be better. Let's work together to do it.
Thank you very much, Professor Margheli, Dr. Schlick. Thank you.